Paul Feuerstein, editor-in-chief of Dentistry Today. And today, we're going to touch on something that every dentist has to know and thinks they know and really doesn't know. And I'm here with Tom Lee. Tom, how are you?
I'm doing very well, thank you. How are you doing?
Good. And Tom is the president and owner of Panadent. And you would say, Panadent, I know that name. Isn't that something to do with articulators? So Tom, why don't you tell us a little about Panadent, first of all?
Well, Panadent
And
was
yourself.
founded. Panadent was founded by my father, Dr. Robert Lee, who did studies on how people chewed, and it was published in the JPD in 1969. It was called Jaw Movements Engraved in Solid Plastic for Articulator Controls, and that led to the development of the Panadent Articulator System. Of course, he passed away back in 1997, and with the driving force of the company gone, I started working with many top educators around the world to see what they're teaching and how they could teach that with our instrument. And so we started developing how to implement aesthetics in articulation as well. So a long history. We have 3 generations here. My mother just recently passed away. Of course, myself and my kids are working here. So it's a family affair, but our purpose is to provide quality, innovative products and exceptional customer service.
So when I was in dental school, we were tortured with these crazy adjustable articulators and had to turn this way and this way and get all these things, do face bows and all sorts of transfers and things like that. And what ends up happening with a lot of dental labs and a lot of dentists themselves is we give a set of models, whether they're regular digital or printed models. And what we get back from a lab is they take this little articulator, little hinge articulator, they put a slop of plaster over here, they slap the bottom on there, wait till it sets, then they take the upper, stick it on there with a bite, take the top, put a little splash of plaster on that, squish it down, and there you go. And the hinge is actually in the back of the mouth, not over here. And this is something that you've been studying and explaining to people for I don't know how many years. So let's go through this whole process and explain what's wrong with this. Why should it be that?
Well, occlusion, of course, is always somewhat been kind of a dirty 4-letter word in dentistry. It's not well understood. And I often say, man, throughout history, when he doesn't understand something like the sun, he'll either fear the sun or they worship the sun. And so many people just kind of fear occlusion in articulation because simply they don't understand it that well. And it really isn't that confusing. I mean, how someone chews is a very complex 3-dimensional movement that includes a brain, muscles, and all these things to accomplish this activity. But the problem with using an articulator that has an axis down here that's in line with the occlusal plane creates a pure vertical movement out of the fossa. Yet when you place it up in the mouth, it goes up here, which creates that down and backward rotation. So I recently was studying this and kind of discovered that any axis below the patient's axis or behind it creates this positive error. Now, positive error is a feature is where the articulator undercompensates for mandibular movements and thus can create a feature on the occlusal surface that either should be non-existent or should be less. In other words, it's an interference that you're probably going to have to adjust. A negative error, basically, where the articulator overcompensates for mandibular movement and thus allows the teeth to disclude more freely. In other words, it may create slighter, flatter anatomy. I know Dr. Coy said, Tom, anatomy is important. And believe me, my father had a concept of dentistry called bioaesthetics, and it was all about the form of the teeth, the form of the occluded dentition in harmony with the form of the joints, helps recreate physiology or function. And I said, yet I've never heard of a dentist complain too much that the anatomy is too good. It's always that they have to adjust too much. And of course, the labs, the first crown goes in like this, the second one's a little flatter, the third one's a little flatter, fourth one's, and so if you go to the dentist enough times, you get a mouthful of flat, amorphic, pathological crowns. And pathology always leads to more dysfunction.
Right.
And dysfunction always leads to more pathology. So it may be future work for dentistry, but really what we should be doing is trying to do no harm and give the patients the best of aesthetics and the best of function.
Well, with this positive and negative, this business that you're talking about, one of the things I would think, and maybe I'm wrong, is that it's going to throw off your anterior guidance completely if you're not sitting, if the teeth aren't occluding properly.
I mean, do they even consider that with the little simple hinge articulators? No.
Not really.
When they place the crown in the mouth, they just put in paper, tap, tap, tap. How's it
Yep.
feel? Oh, a little something. They grind it till the patient says, oh, it feels great. Do they really test protrusive movement, lateral movements with that crown? Some do, but a lot of them don't. So
So
does it affect that? Well, it really doesn't. If you take a protrusive check bite, no matter how you mount the models, if you take a protrusive check bite to that forward downward position, then that would be duplicated no matter where the axis is.
that works. So let's talk about articulation and setting the models up on the articulator. You can't just slap them on us indiscriminately. So a lot of dentists say face bow. Well, I don't mind doing a face bow, but then how do I settle this thing up? But I think you have a kind of nice little system that allows us to sort of figure out the distance between the condyles and the anterior teeth and set the upper teeth in the proper position and then go from there. So why don't you explain that a little bit?
Yes, well, face bows again are often difficult. There's no insurance codes to do that procedure. And do I want to go through all of that for just one restoration or a 3-unit bridge? Plus, they don't transport well to the laboratories. Having the clamps and wrenches and screws, many labs report to me that only 10 to 40% of face bows they receive look correct. And I said, well, wait a minute. Are you telling me 60 to 90% are wrong? And they say, yeah, the vertical post is like this and the bite fork's like this. I know they don't have a vertical plane of occlusion. So I ask them, what do you do? And they say, either I just push the bite fork down about where I think it should be, or I just hand mount the upper model in the articulator of the doctor's choice, and he doesn't even know the difference. So a lot of these face bows done in the name of aesthetic or functional dentistry are often exercises in futility because they just don't transport well. Now, I'm still a firm believer that every dentist should mount their own models and do a diagnosis so they can develop a treatment plan
Right.
that they can then communicate to the laboratory. But it seems like most dentists just prep a tooth, send the impressions over and say, hey, you diagnose it. You develop a treatment plan. Just make it this shade, make sure the margins are sealed, and for God's sakes, make sure that it isn't high. So
worse than that is I've spoken to some laboratory shows, and they say the triple trays that they get are just laughable. Sometimes they get a triple tray and the doctor sends a note and says the patient didn't bite right, so just set it up however.
Yeah, it doesn't make sense. And I was at just a recent meeting with Matt at the aesthetic meeting.
Oh, that's right. Yeah.
Academy of Aesthetic Dentistry. And one of the professors there said the school is now teaching that the triple tray is the standard of care. They're getting away from articulators altogether. It's like, it doesn't make sense. Now, a triple tray, we know the laboratory's number one complaint is poor impressions. And we know that any error in the technique or material of doing an impression will always create a high restoration, never a low. I mean, just think about the logistics of it.
Sure.
So, first, we really need to get everyone that we presume knows how to take a good impression to really learn how to take a good impression. And my father, remember him going to a lab one time, looking through the pans, and he came out and said, it's a wonder that anything the lab does fits in the mouth, because that's the biggest problem there. And you do a triple tray, you only got one side of the mouth, you got one half of the occlusion, maybe one crown, but there's a guidance system on the other side that's controlling some of those cusp angles. It just doesn't make sense.
I can remember getting yelled at by a technician where I was doing 2 molars on one side, sent him a triple tray, and he said, what the hell is this? He says, how am I supposed to mount the entire bite on the right side? You didn't give me the left side. He made me come back and retake a full arch for upper and lower just for the 2 crowns. But just for the 2 crowns, what I would do typically is put those in and have the patient bite and they go, and grind. Okay, that feels good. And then they're completely out of whack on the other side. So that's true too. So I get that. So tell me about this 100 millimeters that you've discussed with me a little bit earlier.
Well, in the article I wrote, I showed that Dr. Kois did some research. It's published in the JPD. and found that, we look at Tedrick and Lundin's work of accuracy of an ear bow, shows that about 75% of the time, an ear bow will get you within 5 millimeters of a true hinge axis. Now, that means 25% of the time, it could be a little further away than 5 millimeters. So Dr. Coyce started doing of course, he has his little building out back, like my father did, with all his mounted models, and started putting them on the articulator and started measuring this axis and sizal distance, and found that actually about 80% of his study was within 5 millimeters of a true hinge axis, which is pretty comparable with ear bow research. Of course, he published his research, and he was looking at discrepancy at the incisal edge based on a 80 millimeter to 120 millimeter axis incisal distance, and found the greatest difference in change in vertical of 3 millimeters was 80 millimeters create 11.26 micron difference at the incisal edge. And I'm thinking, holy moly, seems way too accurate. But then, of course, we had Lux Thompson and their group did some research, and they went back to the axis with like a bunograph or our CPI system, and started seeing where is the axis related to cephalometric, ear bow, and Coyce bow. And they concluded that the Coyce bow was as accurate to a hinge axis as an ear bow, although both of them were significantly off of a true hinge axis. It showed that the two were actually within 1/4 of a millimeter of each other, ear bow and Coyce bow, but both of them were about 5 millimeters away from a true hinge axis, which we've kind of known from Tedrick and Lundin's research, and an ear bow seems acceptable in most fields of occlusion as an acceptable range for most dental procedures.
Sure.
Now, of course, if you're changing vertical dimension and doing extensive rehabilitations, there should be more consideration taken.
So how do I measure that? Do you have something you term the DFA, the analyzer, the dental facial analyzers? Just explain that real quickly for everybody.
Well, the dental facial analyzer consists of a little index tray that doesn't have any clamps or wrenches that's going to distort. You snap it onto the bow, and it has a little wall here in the front.
Oh, I see. Yeah.
If you can see it, and that is where you set the facial of the central incisor. And that picks up 1 point of Dr. Coyce's axis incisal distance.
Got it.
From there, we basically use it like a 3-dimensional analyzer, to where we're not looking at just the horizontal component to the eyes. Now, I do believe that the teeth should be parallel to the eyes if the eyes are level in the face or perpendicular to facial midline. And so over 20 years ago, we developed an adjustable nasion and level gauge for our ear bow.
Oh, yeah.
And started advocating making the bow parallel to the horizon, not to the eyes. And you still got people argue over this fact. So we decided to say, okay. And the problem is it's about a 3-inch difference of where you put the stick to what you're trying to line it to. It'd be much better if we could put the stick right on interpupillary outline. We'd be very accurate at that. So I asked people, okay, forget about incisal plane. What about dental midline? You think about dentures in aesthetics, and dental midline, incisal plane perpendicular to that, posterior occlusal plane, buccal quarters, so forth and so on. Where do you want the incisal edge vertically in the face and anterior posteriorly in the face? So dental midline, do you want that straight or do you want it canted? You all want it straight. Straight to what? Straight to facial midline. And that's why we put the vertical rod on here. So once we set the incisal edge, get the rod to facial midline, so we can see where our dental midline is. And more importantly, do we have a cant to it? Because Kokich's work says you can be off up to 3 to 4 millimeters as long as you're vertical or parallel to facial midline. So it's kind of an aesthetic bow, but has a functional relationship to the axis based on his research, which is substantiated by Bonwill's equilateral triangle. Monson's spherical theory happens to be 4 inches, which happens to be what, 101.2 millimeters. So very close to Dr. Coyce's 100 millimeter average.
This is great stuff, because I think after I read your article, I had to go back and say, curve of what? Munson, all these different things. I had to start reading. We had it in school. We learned it in school, and we don't apply. We just kind of threw it out the window and said, "Yeah, we'll take care of it." And I think you're doing a great service by just being around and teaching to the dentists, but also more importantly to the laboratories to understand these things. So, Tom, you're really helpful to everybody in what you're doing.
Again, it's like you remember that, but you really weren't taught a value in it. You also weren't taught in a way where you understood it. And so you, like you said, you just push it aside. You feared it. See, you feared it. And that's man's natural instinct is fight or flight.
Yeah.
And I'd rather run than try to fight this, because believe me, these meetings back then over centric relation, my dad said they weren't good meetings unless somebody drew blood over centric relation in the hallway.
Oh, we know that. I mean, that's the biggest fights you ever hear of, the different occlusal ideas from different people in different camps, et cetera, et cetera, et cetera. It's been going on since I've been a dentist. That's all I hear about. So, one of the great.
And I hear him fighting, and I often ask him, why do you like to argue over some differences you have when you could actually embrace some similarities? And if there's similarities in different philosophies and different disciplines, now we can institute a principle. And a principle is something you can hang your hat on that will work. And okay, you're both trying to get the joint in the socket. How you're trying to get there with the device you have may be different, but overall, you're trying to somewhat get the joint in the socket. So let's at least agree on that.
And then I just want to say a couple of quick things, is that we're talking all about traditional PVS type impressions and hydrocolloid impressions. And of course, there's a whole digital world out there, but I think it's being overlooked at this point. Maybe they'll get to, maybe you should be a consultant to some of the companies that are doing the virtual articulation, because it's all being done by artificial intelligence and things. And the artificial intelligence doesn't have the intelligence that you have with the theories of occlusion. So it makes me a little bit nervous. I mean, it's cool. You can take, and so we can still do a scan. We can still print a model, and we can still mount a model in a traditional way. And eventually I think it'll turn to a digital format. How it's going to happen there'll be, quote, digital articulators, but still the precepts have to be there. The same precepts about mounting and distances and TMJ all have to be there. So it's not, so people who are going to say, well, we don't have to worry about this because we're doing all digital now. That's not the truth at all, is it?
No, I don't think so. And, how do you verify what you did on the computer is actually correct or not?
Yeah.
Mount conventionally to do any quality control or final adjustments before it goes out to the patient. And believe me, it's more than just instrumentation. I think it's people's knowledge on occlusion itself.
Yeah.
Like you said, incisal guidance, canine guidance, all this stuff. Deprogrammers. I often say, you look at a deprogram. Well, look at the evolution of occlusion in the child. The incisors are up first. It's God's programmer. I don't call it it's God's programmer that we're going to change from moving our jaw forward and back suckling, and we're going to start moving it up and down for chewing. So there's a good reason why to start with something between the front teeth. It helps shut down muscle activity. It helps allow the joint seat to a more physiologic position. Canine guidance, is that really important? It is to some aspect, but if you move your jaw laterally to your canines touch, does that feel normal to you? No, because you don't do that. You actually proprioceptively guide around it. So, what guides our child from age 6 to 12 when they don't have canines? How could God make such a stupid mistake? If canines are so important, shouldn't it be there during the most developing years of our children? Well, what's guiding those six-year-olds? The 6-year molar. And if you ever look, usually that distal buccal cusp falls down slightly out of occlusion. It's kind of like God's surrogate canine. And so when my father did waxing courses, we'd wax anterior 6, but then he'd pop the canines off and say, start waxing the 6-year molar forward. Wax the 6-year molar until you get guidance clearance on the other side.
And then drop it.
And then move forward and get more guidance. Move forward, get more guidance so you get the canines.
That's great.
Kind of what he called graduated buccal cusp guidance.
This is unbelievable. So let me go back. Let's go back a little bit. I want everybody to go back to our July-August issue and read the article that was called "The ABCs of Occlusion and Articulation" for starters. And then how can people get more information, Tom, from you or from the classes that you're involved in or the people that you work with to just learn more
Well,
about this?
they could either call us here at 1-800-368-9777, or I do have a lot of information on our website at panadent.com. And I
Perfect.
produce many videos, presentation videos, as well as demonstration videos. And the demonstration videos are all broken down to, okay, I need to mount the maxillary cast. How do I do? You can go right to that 1 3 or 4 minute video to do that. But yeah, any
That's
questions
great.
you have, there's no stupid questions here at Panadent. I'm not here to necessarily sell you something, although I'd be happy to sell you some
Well,
things.
yeah.
I'm here to try to establish a relationship of a quest of more knowledge and understanding on how to be more predictable to save you time, money, and stress. So it's a win-win-win for everybody, not only for me, but for you, the lab, and the patient that gets successful results. So every day's a good day versus, some days it's like, oh, this thing doesn't fit at all. You got to call the technician, yell him out. And I just don't think it's fair to blame technicians on things that don't fit when a doctor doesn't send them any information other than an impression. I just don't think
Tom,
it's fair.
so let me say something, Tom. We could go on. I thought this would be a quick discussion, and I am sitting here fascinated with all the information that's going back and forth. I've learned even in this little, I thought I knew some things. You gave me a few nice tips as was talking. So I hope everybody gets to this point of the video and watched everything that we've been showing here. And this is just great. It's been just great, real eye-opening. And I think we're gonna have to get back together to go into some more details, because I think this is really important for every dentist to understand.
Yeah, and just to follow with the COISPO, it does have that functional relationship. When we come to the articulator, we have this platform we put in place.
Right.
And, I could remove the index tray, but I could also take the whole bow. Let me just take the vertical rod off and set the tray on the platform. And now
About that top model right there.
that
Right.
wall that's on the index tray is now 100 millimeters from the axis. And so it has that functional relationship. Any cants or tilts of the occlusal plane are in the registration material that's on this horizontal tray. And so that's the relationship there. Now, if we accept that axis incisal distance is good, which research now is substantiating, then we could just, let's say we don't have any aesthetic problems we're addressing. We could just take the maxillary model and set it on the platform with the incisal edge at the 100 millimeter line, creating what Dr. Kois likes to say, a standard functional mounting without a face bow.
Right.
So I'm trying to tell labs, instead of just choosing the small little clamper, use this to mount to a more anatomical axis. Now we can also use that with the new PAL articulator that has a little built-in platform shown in the article.
You mentioned that.
And of course, that little new PAL can also mount digital models, which we can give. What's nice about digital is that you can actually scan this Kois index tray.
Oh, okay.
See, now you can import this in with your impression. And all you got to do is make the attachments to the model parallel to the white tray in the front and the side, and then do the dimensions we have for the attachment. And when you do that, here's the little PAL, but I create these little digital transfer adapters.
Oh, look at that.
And then we can just snap in these 3D printed models at these dimensions. And now that incisal edge will be in the 100 millimeter line on the Kois platform when it's at 0. And it also has that functional axis incisal distance for function. So you can do simple little gentle dentistry without a face bow. So the doctor really doesn't have to do much more. Just say, I want to mount to more anatomical axis. There's other systems out there that do have platforms also. So it isn't just the Panadent. Okay.
But it's learning the concepts from what you're where it really works.
Other systems, people are going, hey, can you mount the COISPO? So they'll create a little platform that has the holes for the COISPO, which means you can use the COISPO for aesthetics in those systems, or you can use a standard functional mounting, as I mentioned, without a face bow. Wow. So it's like, what's your excuse now? And I challenged labs to prove me wrong. I tell them, do your little simple hinge articulator and do your 1 crown or 3 in a bridge. I know it's perfect on whatever instrument you chose. Now let's duplicate those models and mount a second set to this simple hinge
And take a
articulator
look at the differential.
that has a Coy's platform, and mount the upper model, and then move the restoration over and tell me, would you adjust that a little bit more before you send to the dentist? And if you say yes, that could be a lot of what the dentist is adjusting. Now, again, I'd rather them take the crown to the doctor's office, try it in the patient's mouth. Yeah, it's high, mark it. Okay, wait a minute. Yeah, it's marked in the same spot. Hang on. Let me go over here and get it adjusted. Now try it, doctor. Is it perfect now? Well, maybe not, maybe just a little something more right here. But even the doctor will see the difference, I think, then.
I'm looking forward to sitting in one of your classes because this is you're great, you're entertaining, and you have so much information. So I think we're going to cut it at this point here because maybe we'll do it. We'll have to do this like part 2 pretty soon. So Tom, what a pleasure. Thanks for spending some time with me, and it's great seeing you again.
It's my pleasure, and I thank you for the opportunity. And anybody out there, give us a call. We'd love to help you answer any questions and check out our website. Y'all have a great day.
Thanks so much.